we are going to be starting the cardiovascular chapter, which is chapter 6, diseases and disorders of the cardiovascular system. So as always, I will be going by the PowerPoint that I've posted for you as well as your textbook, and we're going to begin on page 90. And let's just look over the anatomy and physiology review, and I'm going to read that, and then we'll start with a little bit of discussion and review of A&P, and then we'll get into the cardiac diseases and disorders. So, on page 90, the main function of the circulatory system is transport of oxygen, nutrients, waste products, electrolytes, leukocytes, and hormones among the tissues and organs of the body. The circulatory system comprises the heart, blood vessels, and blood. The heart pumps blood, and the blood vessels serve as tubes through which blood flows. The arterial system carries blood from the heart to the tissues, and the veins carry it back to the heart. So, we're going to look at the three layers of the heart. You have the myocardium, the endocardium, and the pericardium. So, the myocardium is the actual heart muscle. Myo, remember, meaning muscle. If you can remember your medical terminology or A&P, myocardium is the actual heart muscle, so it's the innermost layer of the heart. Then we have the endocardium, and well, technically, I'm sorry, the myocardium is the muscle, but the endocardium is actually inside the muscle, and it lines the inside of the muscle. And then that's where all of your valves and everything are located. Then we have the pericardium, which is outside of the heart muscle, and so it's around and encapsulates the heart. So those are your three layers of the heart. If you look at figure 6.1, that kind of gives you a good picture of it there. So let's keep going here, and let's talk about the structure and the function of the heart. We have several different valves, and what valves do, they usually stay closed. They're like little flaps, and so when blood rushes in, they open and then they close, and they open and close. So they open for blood to come through, but then they close so no blood runs back through, or blood doesn't keep pumping through. Now, when we have cardiac conditions that are valvular, sometimes we can have like stenosed valve, which means it's like hardened, and it may remain open. And if it remains open, then all the blood is going in and going back, and going in and then sliding back. And so we call that like mitral regurgitation or valvular regurgitation. Kind of like when you vomit, you're regurgitating because your food is coming back up. The same thing when blood goes into the valve and it comes right back out of the valve, because the valve stays open and it's diseased or stenosed, then we have a regurgitation. And then you can have the same thing where the valve is closed and you're not getting enough blood through there. And then that's where, if you think about it, if your valve is staying closed and it's not opening, pressure from the blood is going to start building up, and that's going to cause high blood pressure. So those are the functions of the valve. But we have the mitral valve, the tricuspid valve, and let's look at the mitral valve on page 90. The mitral valve is between the left atrium and the left ventricle, and the flaps on it are called cusps. Then we have the tricuspid valve is between the right atrium and right ventricle, and it has three cusps. So if you can remember, tricuspids have three cusps, and mitral or valve has two cusps. So try to remember that. Then we have the pulmonary semilunar valve, and that has like a one-way blood flow from the right ventricle to the pulmonary artery. And then there's one more. We have the pulmonary semilunar valve, and my mind is going blank on what the other valve is. But anyway, we'll keep going and talk about the terms diastole and systole. You may have heard that dealing with blood pressure. Diastole, or when we have blood pressure, we have systolic over diastolic. And systolic is at the top, and that's how strong your heart is beating. Okay, and then diastole is when your heart is supposed to be at rest, and that's your bottom number. So if your heart is not resting, that bottom number is going to go up and up and up, and if it's resting too much, it's going to be lower. And so that's how we can get like either hypertension or hypotension. Let's see, the coronary arteries. Let's look at those. I'm trying to see. If you look on figure 6.3, you can see the coronary arteries. Those are the ones that feed the actual heart muscle. So they're the veins that kind of wrap on the outside of the heart and feed the muscle. And so usually these are the ones that get blocked by fat, plaque that causes atherosclerosis and can cause heart attacks too. And they're the hardest to detect because they are very small arteries. But just remember that coronary arteries feed the heart muscle, and they're usually the ones that cause heart attacks. Let's see, going on. Let's see. The conduction system. Let's talk about that next. I'm on slide 13 here. Conduction system is very complex, and I'm just going to tell you the basics. And you need to remember this order. The conduction system is basically like the motor that's in a car. It's the motor that gets your heart going, basically. So the very first thing in the conduction system, or the first step, is the SA node, which is a sinoatrial node. And a lot of you may remember from AMP, even in high school maybe, that the SA node is also called the pacemaker of the heart because it jump starts the heart with every beat. Then after it goes to the SA node, we go to the AV node, or the atrioventricular node. Okay, so it goes the SA node, then the AV node. The third step is through the bundle branches, the right and left bundle branches. And then the fourth step, it goes through the Purkinje fibers. So make sure you remember the 4 steps in the conduction cycle: the SA node, the AV node, the left and right bundle branches, and then your Purkinje fibers. Sorry about that. Let's see. I want to make sure I don't need to talk anything else about that. That was the conduction system. We won't go into any more detail than that. Circulatory routes. We have, when we talk about circulation, we have a systemic circulation that goes throughout the body and then back again. And then we have the pulmonary circulation that feeds in the lungs and causes us, to be able to breathe and exchange oxygen with carbon dioxide. Let's see. Want to make sure I'm covering all of this. Let's look at blood vessels. Blood vessels on page 94 and 95. Blood vessels, we have the aorta, okay, and that's really one of the largest vein or arteries in the body. We have after the aorta, we have arterioles. So this is basically going from bigger to smallest. Well, no, not. I mean, in your textbook, I believe it lists like the largest vein to the very smallest, but on this slide it doesn't really go in order. But your blood vessels are made up of your aorta, your arterioles, your capillaries, your veins, your venules, and then your vena cava, which is the largest. That and the aorta are very large arteries there and blood vessels. Let's see. Let's look on page 95 and talk about some common diagnostic tests and procedures that may be used. The easiest thing that's pretty much done on every office visit is when the physician listens to your lungs and your heart sounds with a stethoscope. And when he or she does that, that's called auscultation. So that's one of the easiest things that the physician should do at every visit, is use auscultation to listen to those sounds. Another test is the electrocardiogram. You may have heard it's also called the ECG or EKG. Okay, this is it's not invasive. It's gonna monitor your heart waves, okay, and it'll look to see if there's any conduction system problems. So maybe your SA node is not firing, and that can tell us all kind of things that's going wrong in your heart. Then we have the echocardiogram. Again, this is not invasive, but it's mainly like an ultrasound of the heart, and then we can kind of see how it's pumping, and we can see a little bit more detail. Then we have a Doppler echo, pretty much the same thing. Cardiac catheterization is an invasive procedure. They usually go in the femoral artery and run the catheter up and then through the artery that's clogged, and try to remove it to prevent a heart attack or to stop a heart attack. Angiocardiography is another one, and then coronary arteriography is one as well, and it may even give you more information than that, but make sure you look over all of those and just become familiar with those different tests, and those are on page 95. So look at box 6.1, the bottom of page 95. What an EKG pattern can reveal, or an ECG pattern reveal. And I told you it can tell us all kind of things, but it can tell us if you're having a heart attack. It can also tell us if you've had like an old heart attack present, and your waves do something different when that happens. It tells us if there's a lack of blood flow to the heart, if there's an arrhythmia, heart failure, cardiomyopathy, which is any kind of cardiac disease, congenital heart disease, and heart valve disease. Okay, so it can tell us quite a bit. But then and it's usually a basic test that is done quite frequently. And then if something comes back as showing abnormality, then we can do further testing to know exactly what we're looking at. Okay, let's look at on page 95 again at the cardiovascular diseases. This is where we're going to get into all the actual diseases, but the big thing with cardiovascular diseases is the results of your lipid panel, which is your fats in your body. So you have like a cholesterol, a triglycerides, a HDL, and an LDL. So we're going to talk about all those. When anyone has high cholesterol, it's called hyperlipidemia. Okay, lipid meaning fat, emia, remember, is blood, and hyper is increased. So increased lipids in the blood, hyperlipidemia. Okay, with that you can have lipoproteins, which are called LDL and HDL. LDL stands for low density lipoproteins, and it is your bad cholesterol. Okay, your bad cholesterol. And then your HDL is your high density lipoproteins, and that's considered your good cholesterol. So please remember that LDL means bad cholesterol, HDL is good cholesterol. Okay, then we have triglycerides, and that mainly looks at your metabolism of starches and carbs, and if that's high, usually we have to put the patient like on a low carb diet. If the LDL is high, that's a big indicator, a risk for heart disease. And usually in that case, the LDL may be elevated and the HDL is lower. So when your HDL, your good cholesterol, is lower, then we need to tell the patient that they need to go on a low-fat diet, and the HDL, to bring that up, they need to exercise. Okay, so LDL is all about dieting, HDL is all about exercising. Okay, let's look at box 6.2, page 96. Risk factors for cardiovascular diseases. I'm not going to read all those to you because you can read, but you know that cigarette smoking, a high fatty diet, high blood pressure, all of those are very big risk factors for cardiovascular disease. Alright, going on to diseases of the arteries. The first one we're going to talk about is arteriosclerosis. Arteriosclerosis is hardening of the arteries, okay? And usually this happens after the next one that we'll talk about, which is atherosclerosis. Arteriosclerosis is hardening of the arteries. So basically when plaque from a high-fat diet is building up in the arteries. The plaque hardens and then in turn causes the arteries to harden, and we get arteriosclerosis. So that's what that is. And then your next term is atherosclerosis. And I wish they would have done atherosclerosis first in your textbook, but they didn't. But atherosclerosis is like the actual plaque and fatty buildup within your arteries. And so, like I said just a second ago, when that starts building up, it can turn into arteriosclerosis. Okay? When we have all that plaque building up, it can also harden and break off. And when it breaks off, it's called, and it starts traveling, it's called like an embolus or a thrombus. And so sometimes we can have a thrombosis happen to where, it could cause a stroke, a heart attack. There's a lot of different things that it can cause. It's very dangerous. And that is a very common symptom of a stroke. I'm sorry, a very common cause of strokes is the breaking off of the plaque, and it travels through the arteries. Let's see. Going on, if you look at that figure 610, you can see the normal artery, the lumen, which is like the inside of it, and then you can see when it's constricted, and it can be constricted because of blood pressure, or it could be constricted because of high cholesterol. And then when and that's mainly when we have the arteriosclerosis. And then the last one shows like a plaquey buildup. And so you see when that plaque is in there, blood flow is not going to go through very well, and it can cause a lot of damage. Let's look at peripheral artery disease. Okay, this causes ischemia of the heart. It also causes atherosclerosis. All right. And then it causes intermittent claudication. So we're going to talk about all that. Ischemia is a loss of blood and oxygen supply. That's what that means. The intermittent claudication is pain with walking. So you may have some swelling, but it's mainly, pain in walking. And then, like I said, atherosclerosis is usually happens first, and then we may get the peripheral artery disease, basically where our arteries are just diseased, and it's mainly in our extremities, arms and legs. So legs are usually the most common thing, and when this happens, it can cause blood clots. Okay, and then blood clots can cause circulation issues, and then when that happens, we can get a thing called Raynaud's disease or Raynaud's phenomenon, where we have tingling in the fingers and toes. And so think about it. If you have diseased blood vessels in your legs, and we have peripheral artery disease, and you get a blood clot, and then it starts cutting off the circulation, your fingers and your toes will start tingling, and you'll start to lose the feeling in them. So that's why Raynaud's disease is a common side effect of that. Let's talk about the next thing. Raynaud's disease is actually a separate disorder as well, but it can happen, even though your book does list it separate. Raynaud's disease can happen with the peripheral artery disease because it's circulatory. But then when someone has Raynaud's disease just by themselves, it's, it can happen. Sometimes it can be an indicator of the peripheral vascular disease, or it can be an indicator of lupus or some other type of neuromuscular condition. Alright, now we'll go on to aortic aneurysm on page 98. Aortic aneurysm's not good, very deadly. Okay, so when we have an aneurysm, the aorta in this case is going to dilate. Okay, and we have two different forms. We can do the fusiform aneurysm, or we can have a saccular aneurysm. Okay, let's look at the different types. A fusiform has a uniform shape. It's like tapered at both ends, so it's kind of like a diamond shape, I guess you would say. And then the saccular is just like a round sac. But when that happens, it's like a collection of blood in the area due to some type of artery condition. So this can happen to the abdominal aorta, which runs like from the heart all the way down, and it's in the very back, like right behind your vertebrae. That's not a good thing. Thoracic aneurysm, and then we can have a brain aneurysm as well. So all of these are not good and hard to recover from if a person actually even recovers. Some people may not even know they have an aneurysm until they, all of a sudden die, and then we have to do, they're sent to the coroner's office for a pathology report, and we find out that they have an aneurysm. Let's look at, for as far as things that we can do to look at aneurysms to see if the physician thinks that we may possibly have an aneurysm. They can do like a CAT scan, ultrasound, MRI. Those are your main ones, and then they can actually go into the blood vessel to inject like a substance in there, but that can be dangerous. Alright, going into hypertension, that's a big one. Hypertension is high blood pressure, okay? We've already talked about the systole and diastole. So when we put those with hypertension, we're talking about systolic, which is your top number, and then diastolic, your bottom number. So patients can have prehypertension, where it's not high enough to be considered high blood pressure, but it may be, a little high to say, the doctor wants to monitor you a lot better. Then we can have essential hypertension, which is, your regular hypertension with a certain range of blood pressures. And then a lot of times you can have secondary hypertension, which is due to, from another condition or a medicine that you're taking. So it's considered secondary. The main thing I want you to know with Table 6.1 is that a healthy blood pressure is 120/80 and below, okay? You don't really have to know any of the stage 1 or stage 2 numbers, but I do want you to know that the normal is 120/80. It's about average. 6.2, you can look over that, but again, I'm not going to ask you, what is stroke level, but anytime I can tell you as just a guideline, to go with, that anytime the bottom number is over 100, it usually is stroke level by that point. Alright, let's look, let's leave on page 100 and talk about diagnosing hypertension. A lot of times, it's just taking your blood pressure, and we take blood pressure with blood pressure cuff, which is actually called the sphygmomanometer. Some of you, I'm sure, know that name, but the physician or the nurse or whoever's there will usually take the blood pressure, and over time the physician may monitor and say, you know what, you're still running high. I think I want to put you on a high blood pressure medicine. And then a lot of times you may be having frequent headaches, and you take your blood pressure and it's elevated, so we can catch it that way too. But so usually it's just catching it with taking the blood pressure. And then for treating it, the physician, if it's not bad at first, they may tell you to cut down on your salt, try to lose the weight, try to have less stress in your life, eat a good diet. Those are all things that can decrease your blood pressure. And then if it doesn't happen with that, then they'll start putting you on medicine for it. Okay, let's go on to diseases of the venous circulation. I do want y'all to look over those prevention plus little tidbits on page 100. One is about the risk factors for heart disease, and one is about sodium intake. So look over those really good. It's really, really neat information to find out. Alright, now going on to diseases of venous circulation. The first thing we're going to talk about is varicose veins. A lot of people don't really consider that a medical condition. You know, we just look at them, they're ugly to look at because they're just dilated veins that sit up on top of the skin, and we don't like them, but usually we don't think that it's actually a disease. But it can be a disease, and it can become a really big problem. So, just for official definition, a varicose vein is dilated and distorted veins that usually develop in the superficial veins of the legs. Okay, the most common vein that it's going to happen in is the greater saphenous vein. So you usually get them on the outside of each thigh, around the ankle area is common. And it's because we're weight bearing, and all that pressure on there can eventually start making the vein abnormal. Okay, so when we have varicose veins, it hardens the vein and blood doesn't flow through there very well, and then it can start bothering us and cause a clot. So you can see how this can get out of control very quickly. And then we also have spider veins. Spider veins are similar, except they're not large veins. They're those little bitty blue or pink or red, purple lines that you may see, and we also call them broken veins or broken capillaries. So they have all different nicknames. And again, you don't really associate that with an actual disease. You really just, think that it's just ugly to look at. But again, it can cause a problem because it is a smaller vein. So you have to be careful. Usually, with anything that hurts, with veins that when they hurt, we can say, walk, use support hose. That's the big thing. The compression support hose will really help those veins to basically go back, where they're supposed to go in the legs. Compression sclerotherapy is another term there on page 101 that they give you. And this is where they get saline into a syringe and inject it into the varicose vein or the spider vein to make them basically go back to where they're supposed to be. And it's it can be cosmetic as well. So that's your varicose and spider veins. Let's look at chronic venous insufficiency, or CVI. Basically, this is poor blood return from to the heart. So usually this is very common in middle-aged to older women. Okay, this causes blood clots. Okay, like thrombus or thrombosis. All right, because we're not having a blood going back to the heart and it's pooling in one area. A big common place is behind the knee to have blood clots. Then sometimes that blood clot can break loose and it becomes an emboli, and the emboli can travel and cause a lot of danger. It can travel to the heart, to the brain, to the lungs, or to organs to make them shut down. So there's a lot of risk with that. Again, you can use a compression hose to try to decrease the clots, and sometimes there is some injectables that they can give to, some are more dangerous than others, so there is different types of treatments for that. And usually the patient's in a pretty great deal of pain with these as well. Let's see. Let's go on, and I really already talked about a venous thrombosis. That's really what I was saying was causes the blood clots, and then it turns into the emboli when it starts traveling. Alright, let's go on to coronary heart disease on bottom of page 102. This is also called CHD, and remember, coronary arteries feed the heart muscle. So if we have coronary heart disease or coronary artery disease, which we see as CAD, it can really cause worry for a physician, and they will follow those patients more thoroughly. A big thing with this, when we have coronary artery disease, is we have angina, and angina is just a fancy word for chest pain. So the whole word is angina pectoris. You may hear it called angina pectoris. I've heard it pronounced both ways, so it really doesn't matter to me, but basically it means chest pain. Okay, it can mimic, when somebody has angina, it can really mimic a heart attack. But the big thing here between angina, which is just chest pain, and a real heart attack, with angina, their blood pressure and pulse is not going to change. But with a heart attack, it will change drastically. So that's how you can really tell with that. The patient can start complaining of heart palpitations, okay? Which, and you've probably all had this, or most of you have had experienced this. Basically, when your heart gives a little flutter, and you feel it fluttering all of a sudden, and it takes you a second to catch your breath again, that's called a heart palpitation. Then, like I just said earlier, coronary artery disease or heart disease can cause heart attacks. It's the leading cause of heart attacks. And the medical name for a heart attack is myocardial infarction. Okay, so myocardial infarction is the medical term for heart attack. So to treat this, we can do the angioplasty, where we go in and fix the vein. We may put, some type of stent in there to keep the vein open so it doesn't collapse again or doesn't become filled with plaque again. So that's the angioplasty. As far as other medicines that we may put the patient on before we do, an invasive procedure, we may put them on blood thinning medications like Coumadin, and I think your book mentions warfarin, and that's just the generic name for Coumadin. But we may try blood thinners, high blood pressure medicines, high cholesterol medicines. So the doctor may try several different things before they do angioplasty. It just depends on how severe each patient's disease is. Oh, let's see. If you look at figure 616, this is showing a picture of a bypass surgery of a blocked coronary artery. It's really neat. I like that picture. And then figure 617 shows you cardiomyopathy, which is like a diseased heart. And so it's, unless you really know what you're looking for, you don't really know what part is diseased and what's not. So with that, we'll go ahead and talk about the myocardial diseases on page 104. The first one we're going to talk about is myocarditis, which myo is muscle, remember, cardio is heart, and then itis is inflammation. So this myocarditis is actually inflammation of the heart muscle. Okay? We can, a lot of times this is like associated with infections. Hopefully it never comes to an infection, but a lot of times if we don't treat bacterial infections, like strep throat or something like that, it can cause heart conditions like this, and so we have to be very careful. Let's see. Myocarditis usually has no symptoms at first, okay? But if the patient does have symptoms, it's whatever they're sick with, okay? And if it's left untreated, that's when we can start having, chest pains and breathing difficulty. Treatment for these are usually, we want to kill what's causing the inflammation. So we want to kill the bacteria or the bug that's causing it. Alright, cardiomyopathy, the different parts of that, we have several different parts. We have dilated cardiomyopathy, we have hypertrophic cardiomyopathy, and we have restrictive cardiomyopathy. So let's look in your book and go over these. The dilated cardiomyopathy is the most common type of cardiomyopathy, and it's dilation of the ventricle. Okay, so when you dilate something, it enlarges. So if we have an enlarged ventricle, we may have more blood coming through than we really need to have coming through. This can cause congestive heart failure, okay, because blood is getting congested in the heart and around the heart. Hypertrophic cardiomyopathy, this is very bad. You never want to have this. If we have hypertrophic cardiomyopathy, we usually don't find it out in a patient until after they're dead, because it usually causes a massive heart attack that results in death. So we never want to have hypertrophic cardiomyopathy. Then restrictive cardiomyopathy is the least common, that you may not see a lot. And then basically what happens is when we restrict something, we don't allow it through. And so when we have restrictive cardiomyopathy, we're restricting our arteries and vessels are restricting the amount of blood that's coming in and out. And so that can cause high blood pressure and things of that nature. The main treatment for any of these is to treat the condition of why it's going on, okay? So if it's a bacteria, is it, high blood pressure that's causing it? You want to treat what the cause is of it first, and then that usually will help it get better or make it even go away. Let's look at endocardial diseases on page 105. This is the lining of the inner part of the heart, which includes your chambers. You have 4 chambers, 2 atria, 2 ventricles. So when we have endocarditis, that's what the word is called, and yeah, that's the very first one that it shows you on page 105. Endocarditis is like a condition where the endometrium is inflamed, and it causes these little growths on the different valves in the different chambers of the heart that are called vegetations. So symptoms of endocarditis depends. A lot of times it can be from an infection, okay? Big thing here is infection from rheumatic fever. And the way we get rheumatic fever is usually from strep throat that's left untreated. And once strep throat is left untreated, it turns into rheumatic fever. Once we have rheumatic fever, we're more at risk to develop rheumatic heart disease. Rheumatic heart disease can cause these little growth of vegetations. So it keeps going and going and going. Let's see. To detect this, we can have EKGs and echocardiograms. Some people have to have surgery if the vegetations are really covering the valves up and making them not work sufficiently. We a lot of times have to have valve replacements. So, and that can be a dangerous surgery and a hard surgery to get over. This can also be caused from IV drug use as well. So no IV drug use, and make sure you treat all those infections to avoid getting endocarditis. Then going into rheumatic fever, which I've already talked about, but this is an autoimmune disease of heart tissue and the heart valves. So it's very rare because we are fortunate to have vaccines in the U.S. But however, you hear more and more common that people are not giving their children vaccines, which can be dangerous. And so if we have all these children that are not getting vaccinated, and some children have been vaccinated, they may not have built up a high enough tolerance to fight off that disease that they were vaccinated against. So it can get very dangerous. But rheumatic fever, again, is usually from a infection that was not treated, and then it can cause rheumatic fever, which can cause rheumatic heart disease. If you look on page 105, it says signs and symptoms usually begin 2 weeks after a strep infection. Okay, so with rheumatic fever, you can kind of relate this with like a rheumatism or rheumatoid arthritis. Rheumo meaning like joints. So when this happens, we may have inflamed joints and just very painful to get around in every joint. Some people will start developing like jerky movements all of a sudden, and that can happen. Let's say adhesions on the cusp of your valves can happen, and we definitely don't want adhesions. That's a very bad thing where they're starting to stick all together, because that can just cause a big mess that ends in death. So to treat this, we want to treat that strep throat. Okay, maybe you did treat your child for strep and they seemed better, but they still had it, and so technically they needed to be treated again with an antibiotic. So that's what can cause rheumatic fever and rheumatic heart disease. Excuse me. Okay, going on to diseases of the heart valves. We have stenosis, which I've pretty much already talked about. That was one of the very first things I talked about. And then insufficiency, and then I mentioned regurgitation. So just to go over, stenosis is like a narrowing or hardening of the valve where your blood is trying to struggle to get through. Then insufficiency is maybe when the valve is not closing all the way. It's, abnormal, and so blood may regurgitate, which means like to flow back into the valve when it's supposed to keep moving forward. So that's what those terms mean. So, trying to think. To diagnose this, usually we have to do, usually we can use the auscultation, listening with a stethoscope, and the doctor may hear heart murmurs. Okay, that's a big thing of showing a valvular condition, like mitral valve prolapse. We can hear heart murmur. Now, a lot of you may know this, but a lot of times when babies are born, they have a heart murmur, but the doctor may call it a functional heart murmur and say they'll grow out of it. When it's a functional heart murmur, it's just, their valves are finishing up developing, and then they grow out of it and it goes away. And then some they really have to follow. So I just wanted to add that little tidbit of information there. Let's talk about cardiac arrhythmias. This is like an increased pulse, lower pulse. When we have increased pulse, it is called tachycardia, and when we have a lower pulse, it's called bradycardia. Okay, we can skip a beat, but anything that has to do with the rhythm of our heartbeat is considered an arrhythmia. Okay, and then we have supraventricular arrhythmias and ventricular arrhythmias. So let's look at those on page 106. Supraventricular arrhythmias are generated in the SA and the AV node, and then the junctional tissue. And then the ventricular arrhythmias, these are generated in the ventricular conduction system, which is in the ventricle. So we can have, you have a little bulleted list on 106. You have tachycardia, which is the elevated pulse, like 100 or over. Bradycardia, 50 or less. Ventricular fib or VFib, and then we have a heart block. VFib usually happens right before a patient is going into cardiac arrest. You may have heard it on shows or movies, the patient's in VFib. That's what that means. So the heart is like fibrillating. It's just kind of bouncing along. There's not a wave. It looks like a bunch of squigglies. So VFib is not a good thing, because that means that we need to begin resuscitating the patient. And then the heart block, there's several different types, but and I'm not going to get into all of those. You don't really need to know them, but do know heart block can cause a lot of arrhythmias as well. Anytime we have atrial fibrillation, it's still bad, but it's not as bad as VFib. But atrial fibrillation can cause the fainting, which the medical term that they give you in the book is syncope. So that is AFib, or atrial fibrillation causes syncope or fainting. Make sure you remember that. It can also cause shortness of breath as well. So treatment for these, the ones that we can, try to survive from, is echocardiogram and EKG. I'm sorry, not treatment, diagnostic procedures to do these. We can really see all of these on an EKG. And then treatment really depends on, what type of arrhythmia we have. It varies. Alrighty, going on to congestive heart failure on page 107, which we also call CHF. This is a chronic progressive reduction ability of the heart to pump blood. So basically the blood is being congested in the heart. So your signs and symptoms of this is going to be swelling, okay, or edema all over the body, especially in the extremities. We're going to have shortness of breath, okay. Sometimes we can have chest pain. Severe signs and symptoms are fatigue, limb weakness, neck vein swelling. That's a big thing. If we have distended neck veins, we're really having trouble breathing. And so in our CHF, it's gotten a lot worse at that point. So treatment, we can't really cure congestive heart failure. It's already done, and it really would cause more damage to try to fix it. So we just try to do palliative treatment, which again, if you remember from the very first chapter, means we just treat the symptoms, keep the patient comfortable, and we treat any kind of high blood pressure or low blood pressure that they may have that accompanies it. Excuse me. Let's look at the different types of shock, and then I want you to look at table 6.4 as well, which is right above shock. But shock is when blood pressure drops very low, okay? And when it does that, it's very dangerous because we could eventually die from that. So we don't have an adequate blood supply to the heart. And it can happen for many different reasons. So that's where I want you to look at table 6.4. Cardiogenic shock. Remember, cardio is heart. So this is, maybe it can be caused from a heart attack. We could go into shock from that. Hypovolemic. This means a patient has lost a lot of blood and they've gone into shock. So when they've lost a lot of blood, it's hypovolemic because the volume of blood has drastically decreased. Anaphylactic is one you've probably heard of and are quite common with. This is when we have allergic reaction and it goes into the shock mode where it's a medical emergency. Septic shock is when we have a raging infection and it's considered septic, affecting all of our body. Neurogenic is in the central nervous system. So when we have a lot of damage, like a head injury or something like that, we can have neurogenic shock. So again, look over those types of shocks really well. Let's look at the bottom of page 107 and talk about some congenital and hereditary conditions that are in children. The first thing I want to look at is looking at fetal circulation. Okay, it's a little bit different when they're in the womb still. Their circulation is different. Okay, and then when they come out and take their first breath, the cardiac system has to do like a reroute, and then they get better. So it may take them a minute to start crying, and it's usually they're taking that first deep breath and everything is rerouted and it should start functioning properly by that point. When we cut the cord or cord clamping, we have to cord clamp on each side because if we cut the cord without clamping it, then it would bleed out. We would lose a lot of blood. When we clamp the cord on each side and cut in the middle, we are cutting the lifeline, so to speak, from nourishment from the placenta, and now we're getting, a nourishment by the mother. Let's see. Let's look at congenital heart disease on page 108. Congenital heart disease, a big one that you may hear of eventually is tetralogy of Fallot. Okay, this is happens in the womb still. Okay, and usually the mother will know about it beforehand. And when that happens, we have it's like a hole in the heart, and so we have to be very careful, extra monitoring of this patient that has this. This can also be indicative of like Down syndrome or Tay-Sachs syndrome, Turner syndrome. If the mother has maternal diabetes or hypertension, this can all cause that tetralogy of Fallot. Okay, some other things, we can have like a ventricular septal defect, a pulmonary valve that's stenosed, a misplaced aorta where it crosses and is in the wrong spot, and then we can have hypertrophy of the right ventricle as well. So all of these can be causes of the tetralogy of Fallot. Let's see, going into septal defects on page 109. Septal defects occur between the two aortas, and we have the atrial septal defect, and then we have ventricular septal defects. So if it's atrial, it's between the two aortas. Ventricular is between the two ventricles. These usually have no symptoms. Sometimes when we have the atrial septal defects, it can overload one particular ventricle and cause it to go into overtime, and then it kind of gets lazy after that and doesn't function properly. If it's a huge defect and it's just not correcting itself, then surgery is usually needed. So let's see. Let's look at the patent ductus arteriosus on the bottom of page 1090. This is kind of another similar congenital heart condition in the fetus. When we have the patent ductus arteriosus, the patent artery usually, the ductal artery usually closes before birth. And when it doesn't, again, it leaves that hole in the heart and can cause a lot of problems. So sometimes when this happens, the blood can flow into the lungs and cause, congestion and congestive heart failure. So this is kind of dangerous for a patient or for a baby to have. A lot of times we'll give the child anti-inflammatory medicines to try to fix the ductus arteriosus, and sometimes it helps and sometimes it doesn't. We'll give the baby antibiotics to make sure they don't get a heart infection from this, and then sometimes they can have more invasive procedures to correct it as well. Then we have coarctation of the aorta. And this is like a narrowing while they're in the womb, a narrowing of the aorta that can occur anywhere. Okay, it can occur at the top, it can occur when the aorta splits into the legs, it can occur anywhere. So this can lead to heart failure in children. So again, we have to watch this one extremely closely. And it's actually quite common. With some symptoms that babies may have or that children may have when they have this is dizziness. They may say, I'm dizzy. Some signs, cold legs, because we're not getting that blood circulation into the legs. So we can diagnose this with ultrasound, a CAT scan, echo. There's several different ways we can diagnose this. And then the last thing your book talks about is the age-related diseases. And of course, you've heard everybody talk about when you get older, everything starts happening, but it's actually true. Because as we get older, our body gets more lazy. Everything stops functioning as well. And so that's why we have a lot of elderly people that have a lot of age-related diseases. And it's because they are older and everything's not working as well as it should. So I just kind of touched a little bit on each disease in this chapter, but please read your book and look through the PowerPoint as well, and you should do well on the test. And I think that will be it for today.